So we have first two voided urine specimen. So the first one, the patient do have the past history of flat carcinoma in situ. It's a 71-year-old male. Sometimes in the male voiding urine specimen, we can still see a lot of squamous cells. So these are likely coming from the like a meata of the ureter or something like that. So because the patient do have the past history of high-grade flat urothelial carcinoma in situ, and this would be the cell that we want to look for. Because in CIS, sometimes the shedding cell in the voiding urine specimen would be really scant. So for screening the voiding urine specimen, we want to look for these type of cells, which is hyperchromasia, enlarge of the nuclear size, and you can see the coarsely granular chromatin pattern and increase of NC ratio. So basically, it's very similar to the high-grade urothelial carcinoma cells or a high CO type of cell. So this is the cell that we want to look for. So in this specimen, we have a few, only like two to five of these type of cells. So these groups of cells, these are more degenerated. So you can appreciate that the nuclear is shrinkage, and the chromatin and nuclear contour seems to be not complete. So we cannot make definite call of high-grade urothelial carcinoma by these cells. However, these do looks very atypical, and just based on the prior history, I think this finding is significant. So we need to inform the clinician that they do have some atypical urothelial cells. So these were qualified for atypical urothelial cells. So the next one is also a voiding urine specimen coming from a 76-year-old male. So in this specimen, we have very scant cellularity comparing to the prior one. So we have we have some enlarged cells, but with relatively low NC ratio. So this can represent reactive umbrella cells. But they do have some very strange looking cells, as well as if this is a single cell, this seems to be relatively abnormal. And throughout the specimen, we do have more than 5 to 10 of these atypical cells, and these also show hyperchromasia, coarse chromatin, increase of NC ratio. So the patient also had the past history of papillary urothelial carcinoma at the other hospital and with multifocality. So I think for this specimen, it is okay that we call suspicious because the amount of these atypical cells is much more. The main issue is most of these cells still maintain relatively low NC ratio. However, in some situations in high-grade urothelial carcinoma, sometimes you can find the majority of cells with only like a 0.5 of the NC ratio. So because this type of cell is quite is more than common in these specimens, so I think the specimen is qualifies for suspicious for a urothelial carcinoma. So these are indeterminate cases, but I think the most important issue when we start to learn about cytology, first of all, we need to learn about unequivocal positive cases and then use that threshold to adapt to our indeterminate cases. So this specimen we've seen yesterday, this is a pleural effusion specimen. The patient had lung adenocarcinoma. So in the cytology preparation, it seems to be negative. In the cell block preparation, there is only one single cluster of the cell looks like adenocarcinoma at the periphery. So we do perform the TTF1 for the confirmation. I think just based on the morphology, it's consistent with adenocarcinoma. However, because it's at the edges of the cell block, undetermined if it could be a contamination. Additionally, it's only a single cluster of cell. So here, after deeper recall, we have a different cluster of cell, and you can appreciate that it's inside the cell block already, and it's positive for TTF1, confirm that this is the lung primary. So we can call these adenocarcinoma. It's a early, like a sign for recurrence of disease. So we have a few lung adenocarcinoma cases with recurrence. So during the recurrence, the morphological pattern may be more atypical. So for this case, you can appreciate that this is a highly three-dimensional cluster of cells. And we can appreciate these enlarged irregular nuclei with very prominent nucleoli similar to the size of the lymphocyte, and you need to focus up and down to see through each of the cells in this tight cluster. So this is a high-grade adenocarcinoma, and because it's a recurrence disease, so sometimes the cellularity, the tumor cell will be quite scant. So here is another cluster, also highly three-dimensional, and you can appreciate that the big nucleus, big nucleoli, and everything. The second case is also having a very similar morphological pattern, but this case has more cells. So again, these tightly cohesive cluster with glandular arrangement and with these three-dimensional architecture, and the cells are also very ugly. So this is consistent with recurrence of adenocarcinoma of the lung. So one more case. Again, pleural effusion lung adenocarcinoma. So this is another case of recurrence. So in the background, a lot of inflammatory cells, and then we have these three-dimensional cluster as a second population. So you can see there are also a lot of infiltration inflammation into this cluster, and you need to focus up and down to see through this glandular architecture. So this is also consistent with adenocarcinoma recurrence and scant cellularity. So take a look at these very atypical cells with a triangle shape of nucleus, prominent nucleoli. So this is consistent with recurrence. So let's move to defining the aspiration. So we have some pancreas US guided biopsy. So this one is relatively easy because majority of the cells seems to be cancer cells. So if we compare with the usual type of mucosa cell, which looks more like this, the size of the nucleus are small and regular and with a honeycombing type of arrangement pattern. And then we take a look of this cluster of cells, which show prominent increased size of the nucleus, prominent nucleoli, and very polymorphic looking. So we have these 1 to 4, which means in the same cluster of the cells, the size of the nucleus, the variation is more than 4 times. So this is consistent with the adenocarcinoma of the pancreas, and the tumor cell is quite abundant throughout the entire specimen. And here we have a chunk of stromal tissue which represent the desmoplastic type of stroma which induced by the tumor invasion. So this is consistent with the morphology is consistent with the primary pancreatic adenocarcinoma. Here we have a cluster of a necrotic foci. So this is positive for adenocarcinoma. So a second case of the pancreas EUS guided biopsy. In this biopsy specimen, aspiration specimen, we have majority of the clusters are benign, coming from the duodenum. So here you can see the goblet cell, the nice flattened honeycombing type of arrangement. The cells are all very regular and small with a honeycombing type of pattern. And in cytology preparation, this contrast is very striking. So you can see small normal cells and cancer cell. So it is very easy for us to make a diagnosis of adenocarcinoma out of these type of specimen because we have really nice contrast between the benign and the malignant cells. So let's move to some other aspiration. So thyroid. This is a direct smear. So on low power for this smear, we do see a lot of cells. In the background, we do not see any colloid. So these can raise the suspicions for a neoplasm. However, when we go to a medium power, you can appreciate that there are some very dark staining and crashed material. So these seems to be like crashed lymphocyte that we call lymphocytic tangles. Okay, so these looks like Mao Xianqiu. If you do like weave for the sweater or something like that, this looks like the string of the of that you use to weave, and like all mess up with each other. So this is a classic like a feature for crash lymphocytic cells. And then we start to see in the background also prominent lymphocytic component. So then we move to these epithelial cells. So that looks indeed quite atypical. You see, it almost looks like adenocarcinoma, right? So the size of the nucleus is big, and you have prominent nucleoli. And the cytoplasm is quite abundant and a little bit granular. So these, in the thyroid, these are oncocytes or Herzl cells. So if you see prominent lymphocytic infiltration and these reactive type oncocytic cells, this is a good example of a Hashimoto thyroiditis. So Hashimoto thyroiditis is one of the most common diagnoses that would be overcall in the cytology aspiration. So for this case, you can imagine that people might want to call these as oncocytic neoplasm, like a TBS4, suspicious for oncocytic neoplasm, or something else. But this is a classic example of highly reactive process with prominent reactive changes of these follicular cells. And the patient do has a very high level of anti-TPO. So this is a good example of a Hashimoto thyroiditis. So the next specimen is also coming from possibly thyroid, because the clinician originally labeled the specimen as left neck mass. So there is a pretty big left neck mass, and the clinician didn't specify the location. So the patient do have a sonographic examination. However, because the mass is too big in the sono, it is a little bit difficult to delineate which location, which organ is the mass coming from. The patient also had the CT scan. So I checked the CT scan, and it seems to be, it is coming from the thyroid. So here we have This seems to be a giant cell, but likely like engulfing some colloid material. And then we have a few cluster of cells. So the nuclear feature is suspicious for papillary thyroid carcinoma, but we do not see unequivocal like a nice groove or a pseudo inclusion. And here we do see the cytoplasm is a little bit bubbly. So the overall feature is suspicious for a papillary thyroid carcinoma with prominent cystic change. So here is also a cluster of cells, looks a little bit atypical. So overall in this liquid-based cytology specimen is very scant. And when we turn to the direct smear, which seems to be quite similar. So again, quite loose and not so cellular. And the cellular aggregates has some bubble inside, seems to be like a typical histiocytosis, typical histiocytes, histiocytoid cells. And here is also one cluster of a typical histiocytoid cells. So with some maculation in the cytoplasm, and the nucleus is a little bit oval, a little bit ground glass, but you do not see prominent groove or pseudo inclusion. So I called the radiology, and they confirmed that indeed the lesion seems to be coming from the thyroid. And here we have a nice multinucleated giant cells. So overall, I think the morphologic feature is consistent with cystic PTC. So in this situation, we usually use the TBS 5 category to call these suspicious for papillary thyroid carcinoma. Interestingly, there is one cluster of squamous type of cell. So here you can see some laminated keratin material, and with sort of like a colloid type of material. So maybe the lesion has some squamous metaplasia. We do not see flankly malignant squamous cell carcinoma here, and this is just only one cluster. So this is an unusual case because clinically the clinician cannot decide which location is the mass coming from. They just notice there is a cystic mass with a solid component, looks like a papillary protrusion within the cyst by sono, and the CT scan confirmed that it's highly likely to be originated from the thyroid. And the patient is really old. He's like 80 something, so the lesion must be there for a long time. So there's a breast aspiration cytology. So in this breast aspiration cytology, on low power, it looks very much like a thyroid papillary carcinoma. But when you go to higher power and you appreciate somewhere more flattened, so the nuclear feature is oval and with some vague groove. So it's also kind of similar like papillary thyroid carcinoma, but just the chromatin pattern is not as ground glass as the PTC. And then we have some luminal border over here. So this looks like a papilloma from the breast. So in the breast, if we have cohesive epithelial cluster, which means it's likely benign. So for this cluster, you can appreciate these much smaller, much darker cells. These are myoepithelial cells. So you won't see these in a PTC, in thyroid. So this is suggests that this is the breast ductal epithelium with papillary architecture, and you have still nice lining of myoepithelial cells here and there. So this is a benign papilloma. So next is a parotid gland aspiration. So this is quite cellular. On low power, we can already appreciate some myxoid substance, along with some spindle, stellar shaped myoepithelial cell embedded in this material. And the age of these stromal material seems to be quite fibrillary, so it's very indistinct. So the pattern is consistent with polymorphic adenoma, and here we have some ductal component, some benign ductal component. However, for this case, I just want to show you occasionally in a polymorphic adenoma, you will identify hyaline globule material arranged in a cribriform pattern. So this type of cellular fragment is very similar in what you will see in adenoid cystic carcinoma. So one of the most common false positive diagnosis is to misdiagnose a polymorphic adenoma as adenoid cystic carcinoma. So when you see this type of material, you always need to look for in the background if you have any fibrillary type of extracellular matrix. If you can find fibrillary type extracellular matrix, it is safe that you call this benign adenoid cystic carcinoma. If this type of the material is what you have only, you need to be very cautious, and we will usually recommend you to use the SUMP diagnosis and suggest it is a basaloid with basaloid feature, basaloid SUMP. And because sometimes it can be just like a sampling issue, like a sampling bias of a benign polymorphic adenoma. So again, I just want to show you. So this type of feature is kind of common, not uncommon that you will see in a polymorphic adenoma. So this is resimulating a hyaline globule, but you can appreciate the shape of the material is not very distinct, so it's mostly like a fibrillary. So this one is not easy to be missed, but sometimes you will find the most like a sharp type of hyaline globule looks very much like adenoid cystic carcinoma. So for this case, it is very safe that we can just call this benign because these are all nicely fibrillary. So this is a classic case of PA with some areas suggesting that it might be looking like a hyaline globule. So we have a CIN2 case that we need to have 5-year review of the prior smear. So I noticed that recently when we diagnose high CO, we stop to look for the 5-year prior cases. So please remember when we have the high CO case, please check the 5-year status. So this is the current smear. I think we've seen this case a couple of days before. And the patient turned out to also have HPV testing in our hospital. Yeah, so here is the high CO cells. So it's okay. So we pull out this year at the beginning. There is one smear. We call this reactive no endocervical component, and another one last year. At the end of last year, we call this also negative. So this is from last year. So we have a lot of low CO cells in this specimen, okay? So just a little bit too much. Okay, so please be focused when you are screening. So this is a classic low CO case. And we do not see high CO cells in this case. So this is missed by the screener initially. So for pap smear screening, there must be a chance that we will miss sometimes. So that is also the reason that if you can do it, it is ideally that you do it regularly. So let's go back. If it is coming from the last year, it's a low CO. Sometimes the low CO, the patient will only be observed. We won't do anything until it's developed the high CO. So basically, we don't like change the management of the patient that much. But the other problem is that because the patient was under regular screening, so which that she will be able to identify the lesion through the screening process. So if you are only like do a smear like a 10 years, one time every 10 years, sometimes there's much chance that you will be missed. So this is the specimen from the beginning of this year that we call reactive. In this smear, we only have this cell, and this was originally highlighted by the screener and was sent out for the sign-out doctor. And because we only have this cell, this is like sort of degeneration. It looks might be multinucleation or it just might be a degenerative cells. And this is the only cells that looks now maybe atypical in this specimen. So at that time when we see the specimen, it was like debating it's ascus or negative. Then we decide to call this negative. And at this moment, then we reviewed it again. I think this can be qualified as an equivocal ascus, but very, very equivocal if this is just one cell, looks like this. So comparing to these older specimen, this specimen is particularly low cellularity, as you can see, and also negative for endoscopical component. So sometimes the false negative, the low sensitivity can be resulting from the poor smear, poor sampling. In this case, you can appreciate that it is indeed a poor sampling specimen, relatively low NC ratio and no transitional zone. But the prior specimen is high cellularity. So in this specimen, supposedly, if we are more cautious, this low CO can be identified at the last year. However, it does not change that much of the patient management because it's not until this time when we receive these smears and we identify the high CO lesion, and then she can start with the cone surgery for eliminating the high CO lesion. Okay, so a few take-home messages. First, the low sensitivity can be resulting from poor sampling, poor preparation, as well as the mis-screening. So regular screening is very important because you never know whether this time is miss, that time is low sample quality, and this time we identify the lesion. So if you do it every year regularly, it's more likely you can identify the precursor lesion at the early stage. And usually for the high CO, they will need around 10 years to develop an invasive carcinoma. So during this time, you still have a chance to identify the precursor lesion and treat it as such. So we have a lot of smear, but mostly ascus, and we have a low CO case. Somewhere more. Yeah. So this is not as striking as the prior case, but we do have some more of these, like a superficial cell, multinucleation, hyperchromasia, low NC ratio. So this is, and the amount of lesional cells are quite plenty, so this is also a low CO. This is a 72-year-old female. I would say this is also a quite problematic smear. So in this smear, we see the background have sort of like a degenerative or necrotic material through the direction of smearing. Okay, so you can appreciate that the screener already highlight the area, so you can appreciate that these are this looks like degenerated squamous cell, superficial and intermediate, along with the direction. It looks hyperchromatic, but sort of like a degeneration. And then we will have area of much degenerative type of the squamous cells. So these type of squamous cells looks like tumor diastasis, but it is very scant, and we do not identify good preserved fragments or single cells that qualify for a high CO. But for this pattern, this is not the pattern of a high CO. This pattern looks like an invasive cancer. So what's happened for these patients? So this is getting much more common these days because our clinician didn't do a good job. So when I go to the outpatient notes, and when they do the smear, they put the spatula inside the vagina, and they open it, and it was noted that it says that there's a cystic protrusion, which means that the patient had a prolapse. When you had a prolapse, sometimes the spatula, you really need to pull forward into the end of the fornix and to open it, and then you can get the cervix, which means that the clinician didn't reach the cervix and do the smear in the vagina. And the material over here are all looks like necrotic tumor cells, like debris, like a discharge in the vagina, but they didn't get the lesion in the cervix. So it is a 72-year-old female. She came to our outpatient clinic with vagina spotting. So the most common clinical scenario is the clinician would think that the patient had an endometrial lesion because it's bleeding. But in this case, this is highly likely that this is squamous cell carcinoma. If this is what we have only, I would be very reluctant to directly call this squamous cell carcinoma, although this pattern is definitely more like to be a squamous cell carcinoma other than high CO, because high CO won't have this pattern. But because the patient also had a concurrent HPV testing, which is positive for type 16. So I think it's okay that we just call this squamous cell carcinoma. Okay, so it's getting more and more common because we have a couple cases similar to these. When they do the cervical biopsy, they actually doing the vagina biopsy, and when they do a DNC, and we see a lot of high CO, which is insane because that they didn't know their anatomy, that they haven't reached the cervix yet. So the whole smear is actually only in the vagina. Sometimes you will get the debris from the cervical lesion, sometimes you won't. So we will have a negative smear, but the patient still have a high CO. And it's getting a little bit more common than it should be. And I asked the outpatient, the very senior nurse, and she said, yeah, she also noticed. And some of these, like a junior doctor, they actually don't know how to do the smear correctly. So these can be a fragment of the immature, like a neoplastic squamous cells. So these may be called high CO, but as you can see, it is not as prominent as a high CO, but these can be a mature squamous cell carcinoma. So because the P16 is positive, the patient is symptomatic, and we see the tumor diastasis, I think for this case called SCC is okay. So let's just hope that they can get the biopsy correctly. Okay, that's for all the cases today.